Hi, everyone. Welcome. Thank you so much for joining us today. Let me try to get my ducks in a row. Okay. My name is Amy Sam. I am the Health Education Project Specialist here at the Maxwell and Eleanor Blum Patient and Family Learning Center at Mass General Hospital. Just wanted to give an introduction. So welcome to everyone, that this is a special collaboration between the Blum Center and Mass General Cancer Center. Before we begin, I'd like to go over a few items with you. Please be aware that this session is being recorded for educational purposes. If you're interested in viewing the recording of today's sessions, feel free to visit the Blum Center website at massgeneral.org/Blum-Center. Please note everyone is in listen-only mode. We muted everyone so that we can reduce feedback and hear our guest speaker today. If you're interested in asking a question, please use the chat feature at the bottom of your screen. Only the Blum staff, co-host, and guest speaker will be able to see your questions. Please do not share any personal medical question or information in the chat box. If you have a medical question, please ask your doctor. Next, I'd like to introduce you to Devin Punch. She is the health educator for Mass General Cancer Center, and she'll introduce you to today's speaker.
Thanks, Amy. Hi, everyone, and welcome today. Thank you for joining us. I would like to introduce our speaker today, Kathleen Steinberg. Kathleen joined the Center for Cancer Risk Assessment at Mass General Cancer Center in 2019. Prior to pursuing her genetic counseling degree, she was involved in basic science research focused on human genetic inherited arrhythmia syndromes, endocrinology and developmental biology, and hematology oncology. Kathleen earned her Master's of Science degree in genetic counseling from Arcadia University. And at the Center for Cancer Risk Assessment, she provides genetic counseling services in the breast, ovarian, and GI cancer genetic clinics. Thank you, and I will turn it over to you, Kathleen.
All right, thank you, Devin. Let me just share my screen. All right, are you all able to see that? Great. So again, my name is Kathleen Steinberg. I'm one of the genetic counselors here in the Cancer Center at MGH. And today I will be speaking with you about hereditary ovarian cancer. It certainly is a very important topic and one that I frequently get questions about from patients. As an overview for today's presentations, I'll be covering several different topics. First, I'll provide a brief overview of just the basic functions of the ovaries. After that, we'll talk about some symptoms associated with ovarian cancer. Following that, we'll review some screening options that women have for ovarian cancer. We'll briefly review the different types of ovarian cancer. We'll spend a good amount of time discussing the difference between sporadic and hereditary ovarian cancer. The distinction between those two terms is important to understand the next topic, which would be reviewing the various hereditary ovarian cancer syndromes. As many of you know already, there are many ovarian cancer syndromes, and for the purpose of today's talk, I don't have time to review all of them, but I'll certainly focus on some of the more common ones. And then after that, we'll discuss who is a candidate for genetic counseling and genetic testing, and also what makes someone a good candidate for genetic counseling and genetic testing. And then at the very end, we'll discuss the benefits and limitations of genetic testing. So just again, as a very basic review, I'm sure all of you are familiar with this. The ovaries are an important part of the female reproductive system. If we look at this image right-hand side, we can see that typically women have two ovaries and they're located on either side of the uterus. And the ovaries are more or less connected to the uterus through something called a fallopian tube. Your ovaries have certainly many, many important functions, but one of the functions that they provide is that they produce hormones, including estrogen, which triggers menstruation. In women that are menstruating or getting their period, ovaries also released at least one egg each month into a fallopian tube for possible fertilization. And this is an image of an ovary in a Petri dish. So you can see that an ovary is about 2 centimeters long. And if you look very closely, you might be able to notice that there are some little white dots inside of the ovary. What those are egg follicles. So in each one of those egg follicles is a human egg cell. An interesting fact about a human egg cell is that it's one of the largest cells within the human body and is often visible to the naked eye. And so in regards to the symptoms of ovarian cancer, overall, I would say they're extremely nonspecific. So the symptoms of ovarian cancer can include bloating, pelvic or abdominal pain, trouble eating or feeling full quickly, or even urinary symptoms like urgency or frequency. And so again, these are very, very nonspecific symptoms. Many women experience one or multiple of these symptoms at some point in their lifetime. And typically when women experience these symptoms, they are not a sign of ovarian cancer. These symptoms can also be associated with many, many other non-cancerous diseases or conditions. And these symptoms, given that they are so nonspecific, also points to the fact that ovarian cancer can be very hard to diagnose, particularly hard to diagnose early. When these symptoms are caused by ovarian cancer, they tend to be more persistent in nature versus short-lived. And so a question I often get from patients I see is, are there screening tests for ovarian cancer? Technically, there are 2 screening tests that exist. The first one is something called a transvaginal ultrasound, which is more or less an imaging technique to visualize the ovaries through ultrasound. The second screening test that's available is something called CA125 or cancer antigen 125. This is a blood test. Cancer antigen 125 is essentially a protein that can be detected in the blood, and typically in women that have ovarian cancer, it can be seen at higher levels. And so these tests are sometimes offered to women that are at a higher than average risk for ovarian cancer. And certainly and obviously the availability of them has led to more testing and more surgeries, but very importantly, the availability of these screening tools has not lowered the mortality caused by ovarian cancer. Neither of these screening tools are specific enough or sensitive enough to be able to do that. We really need something better. So I think a better answer to the question, are there screening tools for ovarian cancer, is essentially there are no recommended screening tests that have actually been proven to be effective at diagnosing ovarian cancer at a more early, or you could think of it as a more treatable stage. And so what does it mean to have ovarian cancer? By definition, ovarian cancer is an invasive tumor that originates in the ovary, though it can also start in the fallopian tube or in the peritoneal cavity. And you could think of the peritoneal cavity more or less as the lining of the abdomen or a membrane that surrounds the uterus, the ovaries, and the fallopian tubes. There are many different types of ovarian cancer, but by far the most common is something called epithelial ovarian cancer. And then there are several different subtypes of epithelial ovarian cancer. For example, there's serous epithelial ovarian cancer, endometrioid epithelial ovarian cancer, mucinous epithelial ovarian cancer, and clear cell epithelial ovarian cancer. As you may have guessed, there are also non-epithelial ovarian cancers. These tend to be much rarer, and some of the subtypes include germ cell tumors, sex cord tumors, mixed mesodermal tumors, and borderline ovarian tumors. But again, the most common type of ovarian cancer is something called an epithelial ovarian cancer. And the next slide is risk factors for ovarian cancer. So there are many, many different risk factors for ovarian cancer, and I will review some of them on this slide here. Before I get into this, I will say, though, that risk factors are just risk factors. they're not a determinant. So a woman may have one or several of these different risk factors and never develop ovarian cancer. And the converse is also true. A woman may develop ovarian cancer but not have any of these risk factors. And so that's just important to keep in mind while going through this list. The first risk factor I've noted here is age. And so ovarian cancer, though it technically can occur at any age, is most common in women that are in their 50s, 60s, or beyond. Another risk factor for ovarian cancer is having a family history of ovarian cancer. And so individuals that have one or more close blood relative with ovarian cancer have an increased risk for the disease. The general population risk for ovarian cancer is about 1 to 2%. So that means that the average woman has about a 1 to 2% lifetime chance to develop ovarian cancer. But individuals that have one or more close blood relatives might actually have a higher risk. And the next risk factor for ovarian cancer is something called estrogen hormone replacement therapy. And so current or recent hormone therapy is associated with a small increased risk for ovarian cancer. However, the data shows us that when therapy is stopped, the risk for ovarian cancer decreases over time. Next, another risk factor for ovarian cancer is the age at which menstruation, or getting your period, started and ended. So women who began menstruating or they got their period for the first time at a very early age, or women that started menopause later than is typical, or both, may have an increased risk for ovarian cancer. And then lastly, inherited gene mutations. So a small percentage of ovarian cancers are caused by gene mutations that a person can inherit from their mom or their dad. And you'll notice that I've highlighted this in yellow because this will be a major talking point for the rest of this talk. But before we get there, it's important to understand the difference between the terms genetic and hereditary. And so how I like to think of this is that all cancer is genetic, but not all cancer is hereditary. And if we take that first statement, all cancer is genetic, what this essentially means is that cancer is caused by mistakes that accumulate in our genes or our DNA in one or several cells in our body that leads to uncontrolled cell division and cell growth. And by definition, cancer is essentially uncontrolled cell division and cell growth. But not all cancer is hereditary. And so here, hereditary cancer implies that a person was actually born with a gene mutation or change in a gene in every cell in their body that increased their lifetime chance of developing cancer. And so to go into this topic in a little bit more detail, you'll remember on the last slide, I had said that cancer is caused by mutations or changes that accumulate in our genes or DNA that leads to uncontrolled cell division and cell growth. So we can ask the question, well, what are these genes that control cell division and cell growth? And the answer to this is largely these genes are called tumor suppressor genes. So tumor suppressor genes are genes that all of us have in every cell in our body. And in a typical cell, which is pictured on the top half of this slide, you could say that tumor suppressor genes in typical cells help prevent cancer from happening. And again, that's because their job is to regulate cell growth. So to make sure cells do not grow out of control and do not divide too quickly. You could almost think of a tumor suppressor gene as acting like a stop sign for cell growth or acting like the brakes in a car. It regulates how quickly the cells grow and divide. However, DNA changes that inactivate tumor suppressor genes, which in genetics we would call a mutation, can lead to uncontrolled cell growth. And that essentially is cancer. And really that's what's pictured in the bottom half of this slide. Another way I like to think about this concept is through this slide. So if we start on the left-hand side of this slide, what is pictured is essentially a healthy group or cluster of cells. And as we all go throughout life, to some degree or another, we all become exposed to various things in the environment that can do damage to our DNA. An example would be secondhand smoke, or another example could be UV radiation from the sun. And of course, there's many other environmental exposures and compounds that can damage our DNA. But essentially what they're doing is they are causing mutations to build up in our DNA, in the cells in our body over time. And as I had said, this all happens to us to some degree or another as we go throughout life. If we go throughout life and we develop enough mutations in our DNA, specifically if these mutations happen in tumor suppressor genes, and these tumor suppressor genes are inactivated, then cells can grow out of control and cancer can happen. And so this is how cancer typically happens. So in essence, all cancer is genetic. Now we can contrast this to hereditary cancer. So in this slide, what this is showing a person who actually was born or started life with a mutation in a tumor suppressor gene in every single cell in their body. And so for these individuals, just like the rest of us, they also can go throughout life and become exposed to things in the environment and acquire different changes in their DNA or acquire new mutations. But you could imagine that someone who is born with a mutation in one of these important tumor suppressor genes might develop cancer quicker or more frequently or earlier in life. So in another way, you could say that some people are actually predisposed to develop cancer. And so what percentage of cancers are due to an inherited gene mutation? And the answer to that is about 10%. So about 10% of all cancer is hereditary. The most common type of cancer by far is something called sporadic cancer, or you could think of that as more or less random cancer. And this explains about 70% of cancer. So an example of sporadic cancer would be, say, an individual who's been a very, very heavy smoker their whole life, and then they develop lung cancer. In that case, I would say it is most likely that their exposure to cigarettes and smoking is what contributed to the lung cancer, and less likely that there were genetic factors that contributed to that lung cancer. So I would say that's an example of a sporadic cancer, or the more common type of cancer. The next slice of the pie here is familial cancer. And so about 20% of cancer is familial. And how I think of familial is just that it's cancer that's due to a combination of environmental and unknown genetic factors. And then the smallest slice of the pie is something called hereditary cancer, which we already spoke about. So again, hereditary cancer explains about 10% of all cancers, and essentially it's cancer that occurs or is due to an underlying gene mutation. And so to dive into this in a little bit more detail, what does sporadic cancer look like? So sporadic cancer can look like an affected individual, meaning someone with cancer, who really does not have a strong family history of cancer. So if I see an individual who maybe has one or two different cancers in their family history, that can make me think it's more likely that that cancer in the family is sporadic rather than due to hereditary causes. Also, sporadic cancer can look like an individual whose affected relatives or relatives that have cancer have all been diagnosed over the age of 50 or later in life. So as we all know, everybody can get cancer, but typically when it happens at an older age and not a younger age. So if I see a family where there are a couple people that have had cancer, but it's all much later in life, I'm more likely to say that's likely sporadic cancer and not due to genetic factors, or not due to inherited factors. And then lastly, sporadic cancer can also look like an individual whose cancer is associated with other more common risk factors. I had previously given the example of lung cancer in a smoker, but also we could say another example could be skin cancer in someone who's had a lot of sun exposure in their lifetime and maybe multiple bad sunburns. Now, again, what does hereditary cancer look like? In a hereditary cancer family, we might see multiple affected individuals across multiple generations. We might also see younger ages of onset, so less than the age of 50. And we might see individuals that have had multiple primaries, which just means somebody who's had multiple different types of cancer diagnoses in their lifetime. We might also see very rare cancers or unique combinations of cancer in the family. For example, in a family where we see a lot of breast and ovarian cancer, or another family where we see a lot of colon, uterine, ovarian, and stomach cancer, we know that there are some hereditary genetic syndromes that can predispose people to develop those particular combinations of cancer. And so if I ever see those in a family history, I'm more inclined to think there could be something hereditary that's predisposing family members to develop these cancers. And I know that some people are really much more visual learners. And so for those people, what I have here is a family tree, or in the world of genetics, we would call this a pedigree, but essentially it's just a family tree. And so in this picture, you might notice that there are circles and squares. Circles typically refer to somebody who was assigned female at birth. Squares typically refer to someone who was assigned male at birth. You might also notice that there's numbers under the circles and squares, and those can correspond to the age at which the person is now, the age at which they were when they passed away, or the age at which they were when they were diagnosed with cancer. You might notice that some of the circles and squares have a line through them or they're crossed out. And so this refers to people who have passed away. And then lastly, you might notice that some of the circles and squares are shaded in. And so this is a tool or a key or an indicator that we use to show us that those people have had cancer in their lifetime. And the type of cancer they've had is written below. And so in this family tree here, what this is showing me is that the person who came to a genetic counseling appointment is a 49-year-old female. And I know that because there's an arrow pointing to her. And in this family, this patient, she told me that her mom had lung cancer at the age of 77, though was a heavy smoker throughout her lifetime. My patient also told me that her mom's mom, her grandmother, had basal cell skin cancer at the age of 80, though reportedly had a lot of sun exposure in her lifetime. And so when I see a family history like this, I'm seeing people that were diagnosed later in life, and also we're seeing, likely or common environmental exposures associated with these cancers. So I would say probably this is demonstrating sporadic cancer, unlikely that there's something inherited that's predisposing these people to develop cancer. And so we can contrast that to this slide. So in this family, again, we have a 49-year-old who came to the genetic counseling appointment, and she told me that her mom had ovarian cancer at the age of 38. Her grandmother had colon cancer twice in her life, once at the age of 44 and once at the age of 60. And her aunt, her mom's sister, had colon cancer at the age of 43. And that sister, that aunt's children, my patient's cousins, one had ovarian cancer at the age of 50, and the other had colon cancer at the age of 37 and ovarian cancer at the age of 45. So in this family, we're seeing diagnoses at a much younger age. We're also seeing people that have had multiple diagnoses in their lifetime. And then we're also seeing, a relatively higher proportion of family members that have had cancer compared to the previous slide. So in a family like this, I'm more inclined to say, there might be something hereditary causing the cancer in this family. This person might be a good candidate for genetic testing, or their family members might be a good candidate. And so now that we understand the distinction between those two terms, we can ask the question, well, what percentage of people with ovarian cancer have a gene mutation that was inherited? So as we had said before, about 10% of all cancer is due to hereditary factors. But when it comes to ovarian cancer, that number is actually slightly higher. It's close to 10 to 20%. So again, 10 to 20% of ovarian cancer is hereditary. And this points to the fact that any woman that has had ovarian cancer might be a very good candidate for genetic testing, because her cancer, ovarian cancer, is more likely to be due to an underlying gene mutation compared to other cancers in general. And so now that we know that 10 to 20% of ovarian cancer is hereditary, ask the question, well, what are these hereditary factors? And so the most common hereditary causes of ovarian cancer are BRCA1 and BRCA2 gene mutations. Some people pronounce these genes BRCA1 and BRCA2. Either pronunciation is fine, they mean the same thing. And some of you out there may already be familiar with these genes. And what these genes are is they're tumor suppressor genes. So we had discussed that in a previous slide. So again, these tumor suppressor genes, BRCA1 and BRCA2, are genes that all of us have. And when they're working correctly, they more or less help protect us from cancer. But if we have a mutation in one of these genes because we've inherited it from our mom or our dad, these genes may not do as good of a job protecting us from cancer. So we might be predisposed to develop certain types of cancer, including ovarian cancer. And I will kind of get into the nitty-gritty of these genes on an upcoming slide. But for now, if we look at the pie chart on the right, we can see, again, most hereditary causes of ovarian cancer are associated with the BRCA1 and BRCA2 genes, but there are many other genes that also are associated with hereditary ovarian cancer, and I'll review some of those genes as well in the upcoming slides. And then you'll also notice in the pie chart on the right that there is still a good proportion of hereditary ovarian cancer that we really don't yet understand. And so this just speaks to the fact that there is a great need for more research in this area. And so as I had promised, I think it could be helpful to kind of dive into the BRCA1 and BRCA2 genes in a little bit more detail. Just because, as we said, they do explain a good proportion of hereditary ovarian cancer. How I like to think of these genes is that I think of them as relatively high-risk genes associated with ovarian cancer, which for me at least just means that these genes confer a relatively higher lifetime risk for ovarian cancer compared to the general population risk. And so, for example, women that pursue genetic testing and are found to have a BRCA1 gene mutation have somewhere between a 40 to 59% lifetime risk for ovarian cancer. And the general population risk, again, is about 1 to 2%. Somewhat similarly, women that have a BRCA2 gene mutation have somewhere between a 10 and 27% lifetime risk for ovarian cancer. Again, much higher than the general population risk of 1 to 2%. And so, as some of you know already, mutations in these two genes cause something called hereditary breast and ovarian cancer syndrome. And just like it sounds like, this particular syndrome is associated with an overall increased lifetime risk for ovarian cancer, as we already spoke about, but also for breast cancer. And so if we look at this table on the bottom, we can see that women in the general population have somewhere between a 10 to 12% lifetime risk for breast cancer. But women that have a mutation in BRCA1 or BRCA2 have somewhere between a 50 to 85% lifetime risk for breast cancer. So relatively a much higher risk. And then something that people don't always know about is that men that have mutations in these genes also have an increased risk for cancer. And so men that have BRCA1 or BRCA2 gene mutations have an increased risk primarily for male breast cancer as well as prostate cancer. And so again, the primary purpose of this talk is to focus on hereditary ovarian cancer, but I did want to dive a little bit deeper into this gene for many reasons, but also to just show that for women that do genetic testing and find they do have a gene mutation, or men as well, some of these genes, they don't just, they're not just associated with an increased risk for one type of cancer, but they may also imply that a person is at an increased lifetime risk for multiple types of cancer. All right, and then some other examples of some, relatively higher risk genes associated with ovarian cancer. Another gene would be a gene called MLH1. And so for women that have a mutation in this gene, their lifetime risk for ovarian cancer is somewhere between 4 and 20%, again, compared to the general population risk of 1 to 2%. And then again, there are two other genes, MSH2 and a gene called EpCAM, and women that have mutations in these genes have an increased risk for ovarian cancer of somewhere between 8 and 38%. And mutations in these three genes and a couple other genes not listed on this slide cause a genetic condition called Lynch syndrome. And in addition to the ovarian cancer risks, Lynch syndrome, I would say, is probably most commonly known as or thought of as to be associated with colon cancer. And so people that have Lynch syndrome, because they have a mutation in a gene that's associated with it, such as MLH1, MSH2, or EpCAM, they have an increased lifetime risk for colon cancer, somewhere between 9 to 61%. And I know that's a big range, but it depends upon what gene you have a mutation in. And that's compared to the general population risk of 4 to 5%. So the average person has about a 4 to 5% lifetime chance to develop colon cancer. Another way of thinking about that is that about 1 in 20 in this country will develop colon cancer. In addition to the colon cancer risks, women that have Lynch syndrome have an increased risk for uterine cancer. So in the general population, we see the average woman has about a 3% lifetime chance for uterine cancer. But for women that have Lynch syndrome, their risk for uterine cancer can be somewhere between 13 and 57%, again, depending upon which gene it is you have a mutation in. And then for some of the Lynch syndrome genes, we can also see some associations with stomach cancer and ovarian cancer, obviously, as we had said before. And so this slide is sort of showing us or demonstrating, as I had alluded to before, that there are many, many other genes out there that may be associated with hereditary ovarian cancer. Some of the genes we know a little bit more about, some of them we know very little about. And so if we sort of take on this table the first line, there is a gene called MSH6, which is actually associated to some degrees with Lynch syndrome. So the condition I talked about on the previous slide. We know that women that have a mutation in MSH6 have somewhere between a 1 and 13% lifetime risk for ovarian cancer. And so I think of this particular gene as more of a moderate risk gene, just because it increases a woman's lifetime risk for ovarian cancer moderately, but not to the same degree that we saw with some of the previous genes we talked about. And then if we look at the bottom half of this table, you might notice that there are a lot of genes where the risk for ovarian cancer that they confer is unknown. And so this is just to show that there are a lot of sort of unknown risk genes out there where we may not know to what degree are they associated with ovarian cancer, or even are they associated with ovarian cancer at all. We may not know. More research is certainly needed. Some of the genes that we've mentioned, importantly, have NCCN, or National Comprehensive Cancer Network, guideline recommendations for ovarian cancer risk reduction strategies. So certainly something that's very important for women that do carry these gene mutations. So to begin, for women that have a BRCA1 gene mutation, their recommendation is to undergo something called a risk-reducing salpingo-oophorectomy, or RRSO for short. It's a surgical removal of their ovaries and fallopian tubes at the age of 35 to 40, and when childbearing is complete or earlier based on family history, comorbidities, and other individualized factors. And this is, again, for ovarian cancer risk reduction strategies. Similarly, women that have a mutation in the BRCA2 gene are recommended to undergo surgical removal of their ovaries and fallopian tubes at the age of 40 to 45 and when childbearing is complete or earlier based on family history and other individualized factors as an ovarian cancer risk reduction strategy. And then we can see these genes that we spoke about a few slides ago, MLH1, MSH2, and EpCAM, which are, as we know, are associated with Lynch syndrome. And NCCN does provide some recommendations for these genes as well. And they are, again, to undergo an RRSO, though an exact age is not specified. Instead, it is based on when childbearing is complete or earlier based on family history, comorbidities, and other individualized factors. And then NCCN also provides some guidelines on some of the more moderate risk genes for ovarian cancer, such as BRIP1, a gene called RAD51D, and a gene called RAD51C. And here the recommendation again is to have the ovaries and fallopian tubes removed at the age of 45 to 50, or when childbearing is complete or earlier based on individualized factors. And then lastly, the only other gene that NCCN really provides some sort of recommendation on in regards to ovarian cancer risk reduction strategies is a gene called STK11. And here, the recommendation is not so much for a risk-reducing salpingo oophorectomy or removal of the ovaries and fallopian tubes, but the recommendation is actually to begin annual pelvic exams at the age of 18 to 20 years. And the reasoning for that is that the particular type of ovarian cancer that's associated with this STK11 gene has a much, much lower risk for metastatic spread compared to the type of ovarian cancer that we see being associated with many of the rest of the genes on this slide. So for most of the genes on this slide, the type of ovarian cancer that is most associated with this is that epithelial ovarian cancer that we had talked about at the beginning of the presentation. And that specific type of ovarian cancer has a much higher chance for metastasis or for it to spread around the body, whereas that is largely not true or different for the STK11 gene. And so, experts have determined that an annual pelvic exam starting at 18 to 20 for women that have a mutation in the STK11 gene is likely a sufficient strategy for ovarian cancer risk reduction. Sometimes I get the question, well, what if a woman has not had a risk-reducing salpingo oophorectomy, though it is recommended because she has a gene mutation? And here, NCCN guidelines state that for those who have not undergone the surgical removal of their ovaries and fallopian tubes, a transvaginal ultrasound combined with that CA-125 blood screen, although of uncertain benefit, may be considered at the clinician's discretion. And so I know we spoke about those two screening tools on a previous slide. And here, although these screening techniques do not reduce mortality for ovarian cancer overall, which again has been demonstrated by several large studies, in very rare cases, transvaginal ultrasound combined with this blood screening tool, CA-125, has been proven to be beneficial. And that fact, plus the fact that transvaginal ultrasound and the blood screening tool is really all we have for ovarian cancer screening, is enough where some doctors or some clinicians will consider offering these screening tools to their patients, particularly if they're at an increased risk for ovarian cancer and have not yet undergone an RRSO. However, a lot of data that we have shows us that these two screening tools can cause possible false positives or false negatives. And so with a false positive, the concern is that these screening tools may indicate that a woman might have ovarian cancer, but then it turns out that's not true. So obviously that might cause a lot of anxiety for that particular woman. Conversely, these screening tools have also been shown to be associated with a risk for false negatives. And so with that, these screening tools might provide false reassurance where they just don't detect ovarian cancer at an early enough stage. And so because there's so many pros and cons to these screening tools, I would always recommend that for a woman who kind of falls in this category of being at an increased risk for ovarian cancer, that they at least discuss, would these screening tools be reasonable for me with their doctor? And this slide is essentially just to show us again that there are genes out there that have no established ovarian cancer risks. And so we don't have enough data to show us, really how strongly these genes are associated with ovarian cancer, or even if they are in the first place. And so because of that, they also sort of logically have no NCCN guideline recommendation. And so for women that undergo genetic testing for these particular genes, if they are found to have a mutation in these genes, their ovarian cancer risk reduction recommendations would be made based on their family history or their personal history alone, not based on the genetic testing results. And so again, because there's so much more to learn with these particular genes, more research is needed. And now, who should consider genetic counseling and genetic testing? As I alluded to earlier, anyone who has had ovarian cancer, regardless of their age of onset, is a good candidate for genetic counseling and genetic testing. And that's really because, as we said, ovarian cancer, compared to all other types of cancer, is a little bit more likely to be caused by hereditary factors. Next, anyone who has a close blood relative with ovarian cancer also can consider genetic counseling. And I would say this is particularly true for people who are first degree and second degree relatives of someone with ovarian cancer. I always think of a first degree relative as being a parent, a child, or a sibling. And an example of a second degree relative would be, for example, a grandparent or an aunt or an uncle. Also, individuals who have a personal or family history of multiple different types of cancer can consider genetic counseling. And again, sort of to apply this to what we learned earlier, people that have a family history of a lot of breast and ovarian cancer might have a BRCA mutation. And again, people that have a family history of a lot of colon, uterine, stomach, or ovarian cancer might have a mutation in one of the genes associated with Lynch syndrome. And lastly, individuals that have Ashkenazi Jewish ancestry, which is essentially Eastern European Jewish ancestry, and they have a personal or family history of ovarian, breast, prostate, and or pancreatic cancer, can also consider genetic counseling. And the reason for this is that it kind of links back to the BRCA genes that we talked about earlier. So technically, anyone in the world can have a BRCA gene mutation, and the risk is about 1 in 400. Everyone has about a 1 in 400 chance to have a BRCA mutation. However, individuals that have Ashkenazi Jewish ancestry have a higher chance to have a BRCA mutation, and that's closer to 1 in 40. So whenever I meet with an individual who says, I do have some Eastern European Jewish ancestry, and I have a family history of ovarian, breast, prostate, or pancreatic cancer, I think, genetic testing really might be beneficial for them, because they might be even more likely to have a gene mutation. And so what to expect for a genetic counseling appointment. During a genetic counseling appointment, there are many topics that we address. First and foremost, we always discuss the impact of genetic testing results on personal cancer risk and medical management. And so when I meet with a patient who's comped contemplating moving forward with genetic testing, we usually discuss, well, how could these results impact my cancer surveillance options? How could they impact surgery options? And how might they even impact medication or chemotherapy options? And so that's something that we would address at the time of the genetic counseling appointment. Next, we typically also discuss psychological implications at the time of a genetic counseling appointment. As you could imagine, some genetic testing and the results that come from it can bring up really a wide array of different thoughts and feelings and emotions. For some individuals, genetic testing results can bring about a sense of reassurance or really a sense of control over their own health care. Whereas for other people, genetic testing results can cause a lot of anxiety or can bring up feelings of vulnerability. And so I think for anyone that's contemplating moving forward with genetic testing, the decision to do testing or not to is certainly a difficult one. And then next, at the time of a genetic counseling appointment, we sometimes also discuss family dynamics. As you could probably imagine, genetic testing results have the significant ability to affect relationships with various family members in, both good and bad ways. And so that also might be something that we, kind of play out at the time of the genetic counseling appointment. And then lastly, we also address issues that have to do with confidentiality and insurance issues such as genetic discrimination. And I'm going to touch on that in a little bit more detail in the slide to come. So in 2008, there was a federal law that was put into place called the Genetic Information Non-Discrimination Act, or GINA for short. And what this law does is it essentially protects people's health insurance and employment status from genetic discrimination. So if a patient opts to undergo genetic testing and it shows that they do have a gene mutation which would mean that they're at an increased risk or an increased lifetime risk for cancer, they more or less would be labeled as somebody that has a pre-existing condition. And so because of the GINA law, their health insurance is protected, meaning they cannot be dropped from their health insurance policy. And also their employment status is protected as it applies to hiring and firing practices. There obviously are exceptions to every rule, but by and large, the GINA law protects health insurance and employment when it comes to genetic discrimination. There are some sort of subspecialty insurance policies that the GINA law does not protect. And these include life insurance policies, disability policies, and long-term care policies. And so typically we would review these sort of topics with a patient at the time of genetic counseling and help them decide, when is the right time in their life for them to move forward with genetic testing if they're interested in that. And so next, what are the types of results that we can get from a genetic testing test? Essentially, there's three. First, a positive. A positive would mean a gene mutation was identified. And that gene mutation we know is associated with an increased lifetime risk for cancer. Someone can also get a negative or a normal result. Some patients, when they get a negative result, feel very reassured and they're thankful that they don't have any gene mutations. And that is, on one hand, it can be good news for them because it can certainly mean that they aren't at risk for any of the hereditary conditions we tested them for. But on the other hand, a negative result can also be a bit uninformative because it can imply that the cause of their cancer or the cancer in their family is still unknown. Lastly, a person can also get a variant of uncertain significance, or a VUS for short, as a result from a genetic test. And this basically means that the genetic test did identify a change in one of the genes that we looked at. However, there isn't enough data at this point in time for us to know what that change means. So we can't answer the question, did this particular change, is it associated with the personal or family history of cancer? Or much more likely, is that particular change just a benign, meaningless variant in the DNA that that person happens to have? So long story short, it is possible to get an uncertain result. And then what do these test results mean, and how do they translate into medical management? More or less, we treat a negative and a VUS the same. So for anybody that gets either of those results, medical management, future cancer screenings would be based on that person's personal history and family history of cancer, and again, not based on the results of the genetic test. And we can contrast that to somebody who does get a positive result. So for someone who has a positive result, their medical management would be based on cancer risks that are specific to that gene mutation. And I'm nearing the end of this talk, but I did want to include some resources for individuals who are interested in learning a little bit more about hereditary ovarian cancer. The first resource that's listed here is my department's homepage, so the Center for Cancer Risk Assessment. So if you're interested in learning more about us, you're certainly welcome to check that out. The next two resources that are listed here, the National Cancer Institute and American Cancer Society, are two great resources for individuals who kind of want to dive a little bit deeper into the genetics of ovarian cancer. And then the last two resources, Force and Bright Pink, are two incredible community resources that can be used for many different purposes, but largely would be a good resource for any woman that has tested positive for a gene associated with hereditary ovarian cancer risks. I also quickly wanted to give a plug for some upcoming Blum Center Cancer Genetics presentations. There's one coming up on August 25th that will just be really a basic review of cancer genetics. There's also another one coming up on October 16th that will talk mostly about how family history is important and helpful in the context of genetic testing. And then there will be another talk coming up on October 20th that focuses more on hereditary breast cancer. And so at this point, I will say thank you. It's been a pleasure speaking with all of you today. Also, thank you for my team. It's an awesome team to work with. And then on the lower right-hand side of this slide, I've also included our phone number for the Center for Cancer Risk Assessment. So if during this presentation you've been realizing that you or a friend or a family member might be a candidate for genetic testing or genetic counseling because of hereditary ovarian cancer in the family or what have you, and you're interested in making an appointment for genetic counseling, you're certainly welcome to reach out to us at that phone number. And I believe we have a couple minutes left for questions. So I will turn it back over to Amy and Devin.
Thank you so much, Kathleen, for your informative presentation. As Kathleen just mentioned, everyone, we do have a few minutes left for questions. So if you do have something you'd like to ask, you can type it into the chat box. And just as a reminder, this webinar has been recorded and it will be posted to the Blum website. Question coming in, is a referral needed for genetic counseling?
That is more of an insurance-specific question. Some insurances do require a referral, but some don't. So I would check with your insurance on that.
If my genetic testing shows that I have a mutation in an ovarian cancer gene, what is the risk to my children and my grandchildren?
Oh, so that's a good question. So for anyone that has, for the most part, for anyone that has a mutation in most of the ovarian cancer genes, for example, many of the ones we discussed today, there would be a 50% chance that that gene mutation would be passed on to the next generation. So essentially, if you are found to have a gene mutation, the chance that your children inherit it would be 50%. And so if for an individual who undergoes genetic testing and we do identify a gene mutation, we would then, the next step would be to invite their children in for genetic testing at an age that's appropriate for them to see if they also are at an increased risk for different types of cancer.
Another question, is a pap smear a screening test for ovarian cancer?
That's a good question. I often get that question. It is not a screening test for ovarian cancer. A pap smear primarily is a screening test for cervical cancer.
My grandmother was diagnosed with ovarian cancer at a much later age. Should I seek genetic counseling?
My answer to that would be, first, if your grandmother is still living, she is the best candidate for genetic testing. Just because if there is a gene mutation in your family that caused your grandmother's ovarian cancer, your grandmother is most likely to have it. However, if your grandmother is no longer living or is not interested in genetic testing, then yes, you would be a very good candidate for genetic counseling. And so we would be happy to see you and to speak with you in more detail about all the pros and cons of pursuing this type of testing. But yeah, it depends upon your grandmother, if she's still living, and also her interest in genetic testing.
We do have a few more minutes if there are any other questions. And I see there's one here. Can a woman in her 80s or 90s still get ovarian cancer?
Yes, that links up very well with the last question. Yes, women later in life certainly can get ovarian cancer. As women get older, their ovaries do get smaller and decrease in size, but they are still there. And so certainly they are still at risk for ovarian cancer.
We can give another minute or so if there are any other questions. That looks like that's all the questions that we have for today. I'd like to thank everyone for joining us again, and thank you, Kathleen, for your presentation and your time today. It was very informative. And again, everyone, this has been recorded and will be posted on the Blum website. Looks like we may have another question. Are you located only on the MGH main campus?
So I personally am on the MGH main campus, but MGH, the Cancer Center, and the genetic counselors have many, many different satellite offices that we see patients at. So we see patients in Danvers at the MGH there. We see patients at Newton Wellesley and many other locations. So you can certainly give us a call and inquire about if there's a location that's closer to you. But we do have many satellite offices, so we try and make it as easy as possible to fit you in. We also are seeing a lot, or I should say almost all of our patients at the moment remotely. So typically we can do a telegenetics visit as well, either over the phone or through Zoom like this. So we do try and make it as easy as possible for people during this difficult time.
Thank you. A question did just come in. Is hormonal replacement a risk for ovarian cancer? And should genetic counseling be done prior to starting hormonal replacement?
Sure. I would think of that question as maybe two separate topics. So to a small degree, yes, hormonal replacement therapy is a risk for ovarian cancer. I am not a medical oncologist, and so if you want more detailed information about that, I would encourage you to ask your doctor. And then in regards to should genetic counseling be done prior to starting hormone replacement therapy, I would say it really would depend upon your personal and family history. So if there's any risk factors, such as the ones we reviewed today for hereditary ovarian cancer, then potentially. But I would say for a woman that really does not have a personal or family history of many types of cancer, and she is being put on hormone replacement therapy, it's unlikely that genetic testing needs to be done. So really the answer to that question, it's based on family and personal history. Again, if you are concerned that you have a family history of ovarian cancer and you're using hormone replacement therapy, we're certainly happy to meet with you to discuss if you'd be a good candidate for testing in more detail.
Thank you again, everyone, for joining us today, and have a great rest of your day. Bye-bye.